Okay, so as a continuation of the lymphatic system chapter, we're going to start talking about major organs like the spleen. The spleen is located in the left upper quadrant, a little bit posterior to the stomach, lateral to the stomach, anterior to the left kidney, and it's actually the largest lymphoid organ in our body. And it has internally a histological structure that makes it unique. So it has areas that are what we call red pulp and areas that are called white pulp. In this red pulp is where you recycle the erythrocytes every 120 days, and in the white pulp is where you keep the lymphocytes. The lymphocytes are actually located surrounding some of these arteries that are branches of the splenic artery, and this is where you have filtration of pathogens from the blood, specifically encapsulated bacteria. Now, externally, the spleen, it is surrounded by a capsule, so that makes it an organ. So remember, the difference between tissue and organ is that an organ has capsule, tissue doesn't. And this capsule penetrates internally, subdividing this spleen into segments. And now, within the white pulp, we have a central artery, and it's around this central artery where we have mostly T cells. T cells are specifically dedicated to kill viruses, bacteria, so cytotoxic T cells, for example. And then outside of these T cells, we have core B cells surrounding these T cells in what we call the lymphoid follicles. And now, outside of these core B cells, we have macrophages, dendritic cells, and some B and T cells. So you have then this artery, the central artery, and then you have T cells, B cells, and then macrophages, dendritic cells, and sometimes B and T cells. So that's what makes this white pulp. So this is the location and the structure of the spleen. So this is the abdominal area, left upper quadrant. This is the stomach. It's located just behind the stomach, lateral to the stomach, anterior to the left kidney. And then this spleen has this convexity externally and this concavity internally. It is in this area in the hilum where you have the splenic artery entering and the splenic vein exiting. So that's the direction of the flow, the blood flow. The blood goes in and then the blood goes out through the veins. Now, if you magnify a little piece of this spleen, you can see red pulp here, and then the trabeculae, which is basically the extensions of the capsule, subdividing segments in the spleen, and then you have the central artery, and then the white pulp surrounding this central artery. Now, the central artery has sinusoids that helps to trap large cells, like in this case will be the red blood cells, and then you have macrophages here recycling the old erythrocytes. And then this central artery, it is followed by this vein, and these veins, when they anastomose, finally they make this splenic vein. So here is the actual view of the spleen. So this is all red pulp majorly, and this is the white pulp. So here is the central artery. Then you have the T cells, B cells, and then macrophages, and all the dendritic cells and B cells and T cells. For the thymus. The thymus is a small encapsulated organ that we have in the mediastinum in between the right and the left lungs, and then it's above the heart. So this thymus has hormones that helps to mature the T cells. It has thymosins and thymopoietins. It is large and active in infants and children because that's the place where we train the T lymphocytes. When we're born, we haven't been exposed to many antigens and bacteria and microorganisms in general, not only bacteria. So as we start crawling and grabbing objects, putting it into our mouth, we start exploring the environment. And part of it is actually making sure that we train our T lymphocytes so that the T lymphocytes can respond to pathogenic bacteria. And these T lymphocytes get trained in the thymus. But as we age and we get exposed more to the environment, then we don't need to have this thymus anymore. So then around 12 to 14 years old, it reaches its maximum size. But then after this point, this thymus becomes smaller and smaller and will be replaced by fat tissue. So then by age 65, you produce like 2% or you mature 2% of the T cells as you did when you were an infant. Why? Because you're supposed to have already trained your T lymphocytes. And then internally, we have in the tissue of the thymus some corpuscles that we call thymic corpuscles. They look like little lumps, and they have T lymphocytes in the medulla, and then these T lymphocytes will either respond to antigens or not. Now, remember that I told you last time that when you train these T lymphocytes, you train them not only to recognize foreign particles, but also to recognize your own tissue. And these cells, these immature T lymphocytes, if they recognize your own tissue as foreign, they're supposed to be clonally deleted. So you can select, you can have a negative selection. So if you have tissue that it is attacked by your T lymphocyte, you have an autoimmune disorder, but you don't want that. So then you will start killing those T lymphocytes. So here's the location of the thymus in between the lungs in the mediastinum. And then if you magnify it, you can see that it has two lobes, one major lobe on the right and one on the left. It's not like the thyroid gland that it has an isthmus. It doesn't have an isthmus in between, but you have a right lobe and a left lobe. And then you have extensions of the capsule towards the middle of the thymus, towards the medulla, that's subdivided into thymic lobules. And then you have fatty tissue that little by little starts replacing the functional tissue of the thymus. So those were the details of all the organs of the lymphatic system. Now let's look into the function. So function in general of the immune system or of the lymphatic tissue or lymphatic system is to give us defense against pathogens and also against cancer. So we have subdivision of the function of the immune system into three lines. First line of defense, second line of defense, and third line of defense. In the first line of defense, we have physical barriers and chemical barriers that prevents microorganisms to entering to our body. So we all born with skin and mucosas. Our oral mucosa, vaginal mucosa, anal mucosa, all these are physical barriers together with our skin. And also, we all born with specific cells, like neutrophils, lymphocytes, and we also born with proteins that help us to fight infections. But the cells, like NK cells, natural killer cells, and leukocytes, like neutrophils, basophils and eosinophils form the first line of defense. And this first line of defense is inspecific, so it responds the same way all the time. Now we have the second line of defense, which is made by the lymphocytes mainly. And these lymphocytes, they are B and T and NK cells. However, NK cells form the primary line of defense, while the secondary line of defense will be made by B and T lymphocytes. And these B T lymphocytes specifically respond in a specific manner to a specific antigen. So it's not the same all the time. And it gets trained with time to respond specifically. So then the third line of defense, which is made by proteins mainly, these proteins will be made by the liver. It's part of the complement system, and it will help the first line and the second line of defense to respond to antigens. So based on time of when you develop these defense lines, the innate or non-specific immunity will be formed before we're born. Again, because we are born with skin, with mucosas, and also with secretions like tears, saliva, and chemicals that are found within these substances. And this, again, is non-specific because it responds the same way all the time, no matter what you get in contact with. Now, something that it is important about this innate immunity is that it takes about 12 hours after the exposure to take action. So it is kind of fast in a way. Now, when it comes to the adaptive or specific, which is also known as acquired, and acquired because you develop it as you already have born, this one, it responds to antigens. Antigens are molecules that can set an immune response. Not all the antigens set an immune response, only what you consider foreign antigens. And foreign antigens actually can be your own when they change the shape. Like if it's a protein in one of your cells and that protein unfolds a little bit, you don't recognize it anymore, then you tag it as a foreign antigen. Now, antigens then are any substances that are capable of generating an immune response. And then you have self-antigens and you have foreign antigens. Now, when it comes to adaptive immunity or specific immunity, you have cell-mediated immunity, which is given by the T cells. And then you have humoral immunity or antibody-based immunity that is given by the B cells. It takes a little time to form antibodies. It takes between 3 to 5 days. So it is not as fast as the innate immunity, but still, this one, it is important, and it is actually long-lasting. Now, something about antibody-mediated immunity and cell-mediated immunity is that both create memory. So that next time that you encounter the same antigen, you can respond to this antigen faster than usual. So it is like when a crook tries to attack you, and then it was the first time. Person maybe steals something from your bag and then goes running and you saw it in the street. What are you going to do the next time that you see it in the street? That's memory, right? Either you attack that person or you call the police, you grab a bunch of friends, and then you grab that crook. So similarly, we have memory with this one, but not with the innate. So details about this first line of defense. Well, the skin is highly protective against penetration by microorganisms because we have several layers of cells. This is a stratified squamous epithelium. We have between 20 to 30 layers of the keratinocytes in the stratum corneum of the skin. And that helps to prevent microorganisms from entering really easily. But this barrier can be broken. Like if you have a wound, then microorganisms can penetrate really easily. Now, in the skin, we have secretions, like the sebum from the sebaceous glands. This sebum forms a chemical barrier because it will create acidity, like what we call the acid mantle in your skin, and with this acidity, you prevent the growth of microorganisms. Okay? And now, in the mucous membranes, like in the gastrointestinal tract or genitourinary tract, we have epithelia, which is not stratified squamous, mostly is simple columnar epithelium, but it can be stratified squamous, like in the vagina during the reproductive stage. But we have also secretions, like acids, that helps to destroy microorganisms with the lower pH. And as well, we have, for instance, enzymes like lysozyme that can break down the cell wall of bacteria. Or we can have antibodies like IgA that also can neutralize these microorganisms. So we have different combinations of items that can help with the prevention of infections. So I already talked about these three: acid, sebum, mucus. Basically, it's also another barrier that helps to trap in the mucosas microorganisms. And then in the skin and mucosa, some cells produce antimicrobial peptides that are called defensins that also damages the microorganisms, the pathogens. Oh, and sorry, let me go back. In some mucosas, like in the respiratory tract, in the trachea, for instance, we have cilia that it just moved this way from proximal to distal or from inferior to superior. This is what we call the mucoescalator reflex. So if something tries to go down to lower respiratory system, this cilia, if it's beating properly, it can take out the microorganisms, hopefully. And that, together with the coughing reflex, helps to get rid of microorganisms. Now, our body is populated with many microorganisms. This is what we call the normal flora. They are of different types. They are found everywhere in our body, and it helps to prevent infections with pathogens because these microorganisms, what they do is they bind into receptors in the skin that the pathogenic bacteria can use to penetrate into our body, to adhere into our body and then penetrate into our body. So then actually we have more microorganisms in our body, more cells, part of the normal flora than actually our body cells. And then some of these normal flora as well secrete substances that, together with this acid mantle, helps to prevent the growth of pathogenic bacteria. And now, some bacteria actually can penetrate into our body either through a wound, or maybe it would use some enzymes, and it can penetrate through a non-wound area. These enzymes are called, in this case, collagenases, because they can break down the peptide bonds between collagen fibers. And then an example will be Clostridium perfringens, which is a bacteria. It's an anaerobic bacteria. It grows in the absence of oxygen. And this can destroy the collagen in the basement membrane of our dermis and can go into deeper tissues and cause an infection that's called gas gangrene. So this gas gangrene, it is characterized by necrotic tissue. So you can see areas of the skin infected that looks dark, and then you have bullae. Basically, you have like a bump in the skin, but this bump is produced by a gas bubble that is trapped within the dermis. Because this bacteria, it produces malodorous gas inside the wounds. And then you have also some microorganisms like blastomyces israeli, that it's a yeast that can be resistant to phagocytosis. So it has a very thick wall, so the macrophages cannot attack it really well, and it can produce infections that are deep infections. We also have others like Cryptococcus neoformans or Histoplasma, which are also fungi that can survive inside macrophages. And then once they penetrate into a wound, they can be ingested by the macrophages, they can be carried into the body, and they can cause what is called systemic infections. So then we have acid-tolerant pathogens, like for instance poliovirus, that when goes into the digestive system, it can prevent destruction by the acidity of the stomach, and then can infect our nervous system. This is one of these preventable diseases through vaccination. We have polio vaccine available. And with all these changes in vaccination scheme, I mean, in New Mexico, they still are required. But it seems like they wanted to make this optional, this and measles. And these infections are not good to have. Kills children and adults as well. So then poliovirus is a serious infection. And then we have Helicobacter pylori, which is an infection produced by a gram-negative bacteria. It's a type of classification of bacteria that can also survive the acidity of the stomach. Okay, now for different functions of the cells. So we have this is going to be a reminder from the blood chapter. So we have a subclassification of the leukocytes or the white blood cells into agranulocytes and granulocytes. Granulocytes will be the cells that have granules with enzymes like neutrophils, basophils, and eosinophils. And then we have agranulocytes that they don't have granules, like the B cells and T cells, the lymphocytes, and the monocytes. And natural killer cells are also agranulocytes. They don't have granules, are lymphocytes. This makes like 5% of all the lymphocytes and NK cells. And NK cells, they're called NK cells because, or natural killer, because these cells, they don't need to be previously activated to attack the cells, to kill them. B and T lymphocytes, they have to be previously activated by antigens. So these will form part of the surveillance system of the body, the NK cells. And then in lymphoid organs like the like the lymph nodes, we have dendritic cells that trap antigens, present them together with macrophages to the T cells, and activates the T cells, which are part of the adaptive immunity together with the B cells. And this immunity is called adaptive because it adapts. It is specific, so it depends on what type of antigen or what type of pathogen you find is how you will attack it with this adaptive immunity. Now, we have proteins as well as part of this immunity. So we have the antibodies. The antibodies are produced by the plasma cells, the B lymphocytes. And then I already told you about the five types of antibodies. We will see a little bit more of those, but it's IgA, IgG, IgD, IgE, and IgM. And then complement system, it's a series of 30 proteins that are small proteins, inactive, and then when they get activated, they form complexes, so they start building each other, and the ultimate goal is to form a pore in pathogens, which is called the MAC, membrane attack complex. And then we have cytokines, which are hormones that helps to recruit some cells when these cytokines are released by cells. Examples will be interleukin-1, interleukin-2, and they help to bridge innate and adaptive immunity so that both of them cooperate. So they can regulate the development and activity of the immune cells with these hormones, these cytokines. So how does the lymphoid system and immune system work together? So of course, lymphoid organs and tissues provide the place where the T cells and the B cells can be located. And then you found them frequently in the lymph nodes. MALT, if you remember, stands for mucose-associated lymphoid tissue, and they are also found in the spleen. Now, within these organs, we have these reticular fibers, which are collagen fibers that are randomly oriented, and they help to trap pathogens so that these pathogens can be in the vicinity of these cells, and then you can challenge these cells and that they can respond. So we have within these reticular fibers not only the B and the T cells, but we also have dendritic cells and macrophages that help to activate these B and T cells. So those are the 4 different types of cells that we find in there. B cells, T cells, then we have dendritic cells and macrophages. And this is an example of a macrophage trapping bacteria. This macrophage extends these pseudopods, and then it traps this bacteria and then become active, and then it ingests or endocytoses this bacteria. Where does the macrophages come from? It comes from monocytes. Monocytes are baby macrophages, but they are located inside the blood vessels. Once these macrophages exit the bloodstream, these monocytes exit the bloodstream, they become macrophages. Now, macrophages in some areas of the body has specific names. So, these are the different names. So these are the specific macrophages in different areas of the body. So if they're located in the lungs, you call them dust cells. If they're found in the skin, Langerhans cells. If it's found in the brain tissue, microglia. If it's in the liver tissue, you call it Kupffer cells. And if it's in the bone tissue, you call it osteoclast. And then these cells, the macrophages, they're called APCs as well, antigen-presenting cells, because when they ingest an antigen, not all the part of the antigen is immunogenic, meaning that it cannot activate the immune system. Only certain part of the antigen. And the part of the antigen that activates the immune system is called the epitope. So then, this large antigen, the macrophage ingested, and then it will present the little piece to the lymphocytes so that the lymphocytes can be activated. That's why they are called antigen-presenting cells. Now, the neutrophils, they are highly effective phagocytes because they will secrete toxic forms of oxygen that the microorganisms will be destroyed with. Now, some microorganisms have enzymes that help to prevent damage by these toxic forms of oxygen, but most of the times they don't have. So then, when someone has a bacterial infection, the first cells that get increased in number will be the neutrophils. So the person will have neutrophilia. And these will be like the first responders. Within 24 hours, they increase in number, and then they will release these toxic forms of oxygen, and then the bacteria will be destroyed. And this release of these toxic forms of oxygen is called respiratory burst. Now, eosinophils can also phagocytose pathogens, and they release granules. That's why they are granulocytes together with the neutrophils and eosinophils. And these granules have molecules that can damage the parasites. So when someone has an infection with a parasite, it has increased number of eosinophils. You will have eosinophilia. Now, the dendritic cells, they are the most important APCs, antigen-presenting cells, and they are found in the skin, and they're called like the Langerhans cells, but also they are highly present in the lymph nodes. So they have substances, and they ingest these antigens and present it to T cells and to some extent to B cells so that they can become activated. And then with these substances that they ingest, they can bridge the innate immunity with the adaptive immunity. Now, the NK cells, as I told you before, they don't have to be activated previously to respond. But not only they respond to viral infected cells, but also to cancer cells. So they are always circulating throughout the body trying to find something that they find irregular. And then the substances that they release are cytotoxic that can activate macrophages. Basophils, they have a lot of granules that they are inflammatory mediators like histamine, heparin. And then with these, they will activate the cascade of inflammation, and they also can trigger immune system responses, like allergic responses. For the complement system, we have, again, like around 30 proteins that has a letter C to designate this protein, and then they have a number. And they can be activated by 3 pathways. Classical pathway, which is when the complement system binds to proteins, antibodies that are already bound to an antigen. The lectin pathway, which it binds to carbohydrates in certain microbes. And then the alternative pathway, which is when you cleave an inactive complement protein that is called C3, and then you activate it to form the C3b. So here is the different pathways for the complement system. So here is the classical pathway in which you have an antigen bound to antibodies. So in this case, the complement system binds to this part of the antibody. Then if you have a microbe that has certain proteins in its surface, then this lectin protein will bind to this, certain carbohydrates, it will bind to this. And then the alternative pathway is just cleaving this C3 into C3a and C3b, and then all of these pathways, the alternative, lectin, and classical, merge in this area where you have activation of C3b, and then with this C3b, you can neutralize viruses because it attaches to the surface of viruses, or it can coat bacteria, and with this coating, the macrophage get attracted much easier to this bacteria, to endocytose this bacteria. So this is called opsonization. Yeah, sometimes I compare this as when you have a cake and you frost the cake and you decorate it really nicely, it will make it much easier or more appealing for you to eat it. So this is called opsonization, coating bacteria with C3b. Now, C3b also can form a complex with immune system complexes, and that will help for these macrophages to much easily detect these immune complexes and then be endocytosed. And then when you activate C5, you will form cell lysis with the MAC, membrane attack complex. So that is going to make a pore within bacteria, and then this bacteria will be lysed. Or you can basically activate the inflammatory process by releasing some of these molecules. Any questions? So for enhanced inflammation, you use C5a and C3a. That triggers mast cells and basophils to release chemicals. For cytokines, we have different types, including something that's called TNF, tumor necrosis factor. And in this TNF, you will have the activation of fever, And that also, if you have excess of this, you will have something that's called septic shock, in which the person will have low blood pressure, kidney, liver failure, and inappropriate blood clotting and bleeding. You can also have the formation of interference or IFN, in which if you have virally infected cells, these virally infected cells, so let's say you have cell number 1, 2, and 3. And then cell number 2 get infected with virus. So this is a virus. So this cell, after it gets infected with virus, is going to release cytokines that we know as interferons or interferons. So then neighboring cell 1 is going to endocytose these interferons, and then also neighboring cell 3, and these two become immune or protected against viruses. Not all against a particular virus, the one that it was infecting this cell. It's like a good neighbor that tells you, well, my house got broken in last night. There's a burglar around the neighborhood. Make sure that you are in a watch. So that's the interference. We actually produce this artificially with molecular biology techniques to help with infections like, for instance, hepatitis C. Let me see if this animation plays.
Does interferon treatment stop it or just help?
It treats it.
It just treats it, but it doesn't make it go away, right?
No. Let's see. So we're going to play an animation, hopefully it plays, about interference.
It's like it explodes, huh?
Yeah. All right. There's our animation. So then we have other cytokines like interleukins, and interleukins are many of them, uh, but we have one that is called IL-2, that this one stimulates the production of neutrophils and NK cells. And when these become activated, uh, these cells, together with the T cells, you have the production of this interference. And again, you use this artificially to treat infections. It doesn't cure them, especially for hepatitis B. Hepatitis B, once you have it, you will have it forever. Hepatitis C, some cases they recede, but not for hepatitis B. Another use will be for treating cancers like melanoma, but they have a secondary effect, like the person will have flu-like symptoms, as you saw from that animation. Any questions about interferons, interleukins, or anything that we covered so far? Okay, now for inflammation. So inflammation, it's a body response, part of the innate immunity, and this can be given in response to injury because you have damaged cells that release inflammatory mediators, chemical mediators of inflammation, or because you have some phagocytes that arrive at the area and then they will be cleaning up, as they're cleaning up the area of damaged tissue, they will release chemicals that can cause inflammation. So, first part is that you have tissue damage. And then these cells will release chemicals that are going to attract neutrophils and that are also going to attract other cells. And then you will have the release of histamine, serotonin, cytokines, bradykinin, prostaglandin, leukotrienes. All of these are chemical mediators of inflammation. One of the first things that is going to happen is that you will open up the endothelial cells of the surrounding tissue, and that is going to lead to the escape of cells of the circulatory system, including macrophages, into the area of injury, and also blood and blood cells like red blood cells and white blood cells. That not only is going to be the monocytes that become macrophages, but also is going to be the neutrophils. And then when these neutrophils start releasing the chemicals, like let's say that it's a bacterial infection that they're trying to attack, these chemicals are not going to only kill the bacteria, but also going to damage the normal cells and other neutrophils. And then you have more release of these chemical mediators of inflammation, all of these, and that increases inflammation. Now, some of these cardinal signs, which is redness, heat, swelling, and pain, will be important for controlling, in this case, an infection. So with redness, basically as you increase the blood flow into this area, you increase the local temperature, and that will decrease the growth of microbes. And as well, you will be recruiting these cells like neutrophils, monocytes that will become macrophages, and then you start fighting these bacteria. And then with swelling, you will compress other blood vessels that are nearby, and that will prevent the microbes entering into the bloodstream. And then pain will help you because you will seek attention, or you take care of what is going on in there. So then these are the 4 cardinal signs: redness, heat, swelling, or edema, and pain, which is rubor, calor, dolor, and tumor. Now, inflammation is good because after you fight the infection or you take care of whatever injury is happening there, you can also start repairing process. But sometimes the body over-responds and you have chronic inflammation. And chronic inflammation is not good, so you have to control it. In this case, you can use some drugs that can decrease these enzymes or these molecules that causes inflammation. Like, for instance, some of the common types of anti-inflammatory drugs will be aspirin, naproxen, diclofenac. So they can deactivate some of these enzymes that produces these prostaglandins, like cyclooxygenases, lipoxygenases that exist in the plasma membrane. So you're trying to reduce the number of prostaglandin and leukotrienes, which are chemical mediators of inflammation as well. So an example then of another drug is ibuprofen. This is an NSAID, so non-steroidal anti-inflammatory drug. And then you can use also corticosteroids, which are more powerful, but they have, just as these ones, they have secondary effects. I mean, one of these secondary effects of taking many of these is to cause irritation of your stomach, so you end up with gastritis. And also some of them inhibits the clumping of the platelets, because some of these enzymes, like cyclooxygenase, can be used to help to clump these platelets. So then the person will bleed much easily. And in the case of corticosteroids, when you take it chronically, well, it can damage your adrenal cortex. And then you end up with Cushing syndrome, which is something that we will see later in the renal system chapter, more than likely. But any of these, when it's taken inappropriately, can lead to problems. So then details about these cardinal signs. About the edema and the redness. Well, edema happens because you have release of plasma and blood into the environment because you open up your endothelial cells. So remember, endothelial cells are continuous in the blood vessels, but with these chemical mediators of inflammation, you open them up, so you leave a gap, so plasma exit, and then you produce edema. So you have vasodilation of the arteries, and then increase of blood flow lead to hyperemia or redness. So that leads to congestion of blood. So here is an illustration of this process of inflammation. So in this case, someone with a splinter damages the skin, you produce a wound. So let's say that you have bacteria in the tip of this splinter. Then you damage your cells release chemical mediators of inflammation. That leads to the chemotaxis or attraction of cells like mast cells that are going to release these chemical mediators of inflammation into this area, this damaged area. And then these chemical mediators of inflammation, let's say that it's serotonin or these other chemicals, opens up these capillaries. So the capillaries has protein rich fluid like plasma, so that exits here. So this is called extravasation. And then as well, you will have this exiting of the neutrophils and monocytes. First neutrophils within 24 hours, this can take up to 72 hours. And then they will start fighting any bacteria that you have in here. And also they release more chemical mediators of inflammation. And if you have, well, most than likely you will have nerves in here. So you will have the release of some substances that can activate these nerve endings, and then that produces pain and possible loss of function. So recruitment of cells happens through chemotaxis. So chemical mediators of inflammation attract and inactivate leukocytes, macrophages, and then even complement system. So here we have erythema in darker skin, which is redness, and erythema in lighter skin. Any questions? So through chemotaxis, then your monocytes become macrophages, and then if there is anything that is left over here, macrophages clean up the area. And if you have a particular bacteria in here, you may have opsonization with the complement system like C3b. Macrophages become more active and then they start cleaning up. So basically macrophages will be the janitors while the neutrophils will be the soldiers. So they first arrive, they kill bacteria, and then macrophages later on come and clean up everything. So remember, macrophages derive from the monocytes. Monocytes are in the bloodstream, they exit and become macrophages. And then these leukocytes can undergo mitosis, so you can have formation of these leukocytes along this area in the bone, so that you can have increased numbers to fight infections. And some bacteria that can produce pus in the wounds, it will be called pyogenic bacteria. Not all the bacteria is pyogenic, some of them are.
So, Professor Sully, are do the macrophages can do pretty much all the cleanup, or do they sometimes aren't able to do it all? Or does that happen?
It will be the only ones actually. And now, one difference between acute inflammation and chronic inflammation is measuring the number of monocytes and neutrophils. Like if you have an acute infection, neutrophils is going to be high, so you have neutrophilia, and also lymphocytes as well. But when you have a chronic inflammation and chronic infection, you will have high levels of monocytes. So you have monocytosis and you have lymphocytosis. So that's one way that you can differentiate. And now, as these macrophages are eating up the bacteria, they release tumor necrosis factor. And that TNF is going to reset the thermoregulatory system in the hypothalamus, and then you will have fever. So fever will be defined as temperature above 37.2 degrees Celsius, or 99 Fahrenheit. So this is the normal body temperature, between 36.5 and 37.2, but above that, it will be fever. So chemicals that activates fever are called pyrogens, and it will be not only the macrophage itself, that produces these pyrogens like TNF, but also some bacteria release molecules like gram-negative bacteria. Is one type of bacteria releases LPS, lipopolysaccharide, and then this one increases the body temperature. So why we have increased body temperature during infections? Well, you wanted to control microbial growth. And one way to control microbial growth is having higher body temperature. And then if the body temperature, which is very high, affects your body, then you give drugs, antipyretics, that decreases the fever by inhibiting the formation of prostaglandins. An example would be paracetamol. And some anti-inflammatory drugs like ibuprofen, they also have this antipyretic effect. So this is the summary of first and second line of defense. I'm not going to go over that, but you have it there. Any questions so far? Okay, so in this next part, we're going to look at details about the adaptive immunity, like cell-mediated immunity in this case. Cell-mediated immunity is given by T lymphocytes. So B and T lymphocytes gives you different types of immunity, although both are part of the adaptive immunity. So this type of immunity can be subdivided into cell-mediated, given by T cells, or humoral immunity, given by B cells. So with T cell or cytotoxic mediated immunity, you control infections in cells and also cancer, hopefully. And then with humoral, you control infections in the fluids in our body. Like if you get an infection, viruses or bacteria in the cerebrospinal fluid, pleural fluid, etc., any kind of fluid, then you have your antibodies with the humoral immunity. Now, cell-mediated has different classes of T lymphocytes. Helper T cells or Th cells, which are also known as CD4+. These are the lymphocytes that are destroyed by HIV. And then we have cytotoxic T cells or T cells, TC cells, which are also known as CD8+. And these ones, they are directly attacking the cells that are infected. Helper T cells, the name it tells you, basically it recruits CD8 B cells to improve the immune response. So when someone has loss of these helper T cells, the person unfortunately won't be able to fight infections as easily because he won't be able to recruit other members of the immune system. Now, this CD stands for cluster of differentiation, which are specific antigens found within these cells. And these are molecular markers. If you see these cells in light microscopy, the lymphocytes, you cannot tell whether it's a B cell or a T cell. And even if you were like having a wild guess and then, yes, this is a T cell, you won't be able to tell whether it's helper, regulatory, or if it's cytotoxic, just because these are molecular markers. They're very tiny molecules. So then here are the responses for cell-mediated immunity. Is for cells that are infected with intracellular pathogens like viruses or intracellular bacteria, cancer cell, and foreign cells from a transplanted organ. So then T cells attack cells with viruses or intracellular bacteria. Plus cancer cells or foreign cells from a transplant. So that's the cell-mediated immunity. So for details about the antigens, again, antigens are molecules that are capable of eliciting an immune response. And then they can be peptides, but also can be carbohydrates, lipids, metals, dust, dander. It can be an organic molecule or an inorganic molecule. As long as your body doesn't recognize it as its own, it can be immunogenic. So self-antigens are not immunogenic, and haptens are very small antigens that they need to have a carrier, a protein carrier, to be immunogenic. Examples will be urushiol, a toxin in poison ivy. This one has to interact with the proteins in our skin to become immunogenic. So antigens can be subclassified as exogenous if it originates from outside the cells and must be taken by the cells by phagocytosis. Or it can be endogenous, which can be either an antigen that it is foreign, that is presented on a pathogen that lives inside your cells, like an intracellular bacteria, or can be a foreign or a self-antigen encoded by your DNA. When this antigen loses its shape, can become a foreign antigen. Like cancer cells, some of them, they can have some antigens that can be detected by your body. Some of them, they can have it in the surface of the plasma membrane. In this case, it's easily recognized. But some of them, they can have it in the nucleus. But because it's in the nucleus, our cells don't recognize it. I mean, if all the cancer cells have antigens that can be recognized by our body, and we have a strong immune response, less people will have cancer. Okay? I think we can leave it up to there because this is going to take a little bit more to explain. But do you have any questions?